Good morning and welcome to the Community Technical Assistance Center of New York. Our webinar for today is responding to the crisis on Black youth suicide clinical implications. This is a part one of a two-part series with our wonderful presenter, Dr. Rhonda Boyd from the Children's Hospital of Philadelphia. We're very excited to have her today to talk us through this very important topic. Today we'll provide a bit of an overview and conversation around what are some of the general implications, risk and protective factors and the like. And then part two, we'll go in a bit deeper. We'll talk about some specific sort of strategies, interventions and the like when working with Black youth. Before we get started, before I introduce Dr. Boyd, I just want to do a little webinar housekeeping. As many of you may see, everybody's muted. Please use the chat box, and good morning to everybody who's chatting in. Good morning and hello. Please use that chat box to communicate with us. Make sure to send to all panelists so we can see your questions and your comments. There may be parts throughout the webinar where we'll ask you to chat in specifically. And we'll also have a Q&A period at the end where we'll be able to answer some of your questions as well. This webinar is being recorded, and the recording and the slides will be posted on the ctacny.org website within about 2 business days. So you'll be able to get access to the recording or share that recording as well as viewing the slides in just a couple of days. So without further ado, I just wanted to introduce our wonderful presenter. Dr. Rhonda Boyd is an associate professor in the Department of Child and Adolescent Psychiatry and Behavioral Sciences at the Children's Hospital of Philadelphia and the University of Pennsylvania Perelman School of Medicine. She's associate director of CHOP's Child and Adolescent Mood Program in the outpatient clinic, where she practices as a psychologist specializing in evaluation and treatment of youth with depression. She has served as a principal investigator and co-investigator on multiple federal grants, including those from the NIH and the Maternal and Child Health Bureau. Recently, she participated on the work group for the Congressional Black Caucus Emergency Task Force on Black youth suicide and mental health. Dr. Boyd, would you like to get started? And welcome.
Yes. So good morning, everyone. I'm glad that you're all able to attend this 2-part workshop, and I look forward to answering the questions at the end. If you have anything that comes up earlier, sometimes we may stop to ask the answers and questions that may come up. So let's get started. So I want to first talk about that this month is the B.B. Moore Campbell National Minority Mental Health Awareness Month. And so I know there's been a change because the word minority is not used in month, to change it to BIPOC Mental Health Awareness Month. But I do want to recognize B.B. Moore Campbell, who was an author and a mental health advocate who helped to advocate for this month being designated. She passed away in 2006, but I do want to recognize that often people may not know some of the work that went behind some of the mental health advocacy. So today we'll be covering 3 main topics: the current prevalence and trends for Black youth suicide, also talking about screening issues, as well as risk and protective factors. So some of the recent data that has been shown, particularly looking at some of the leading causes of deaths for Black youth ages 10 to 17, if you look at the changes. So in 1999, suicide was the 5th leading cause of death for Black youth in that age group. But as of from 2018, it's the 4th leading cause of death. And so it's an illustration of how there's been an increase in youth suicides in this age group that needs attention. And this is sort of why we're here and why the Congressional Black Caucus decided to write a report about this issue. One of the things that I became aware of, this particular article struck me and for awareness to sort of this risk factor. This study came out several years ago, but it looked at differences among Black youth and white youth and the risk for actually suicide deaths. And as you see, for the younger age group, under 12, Black youth are twice as likely to die by suicide than their white counterparts. And this decrease in other age groups as the youth get older. And when I found out about this study and these findings, it surprised me. I was not aware, even though I did work with many Black youth with depression. This finding kind of opened the door of there is a crisis that we were not aware of and what needs to happen, and particularly with these very young children. And this recent report came out looking at some of the current characteristics of Black youth. And what they found is they looked at, in this time frame, what were the leading causes of death, looking at death records. And they found the first was hanging, suffocation, or strangulation, and the second was firearms. And I think these are important things to know about the methods that are used. Because as we encounter youth in different settings, we need to know what types of means they're using and be able to inform families to keep their environment safe. And so knowing this makes a difference, whether there's a firearm in the home. And then what becomes an issue with the hanging, suffocation, and strangulation, there are multiple ways in one's home in which youth can have access to this. And we will have to work with families that try to how to make their environment safe for kids. One of the things that they also recently looked at is among these youth, what were some circumstances that were identified prior to the deaths? And so what it may look like for Black youth may differ from other groups. So it was found that a high portion of Black youth who died by suicide, there was a crisis immediately preceding the 2 weeks. They were having a relationship, a family relationship issue. There was an argument or conflict that occurred, and there was a history of a suicide attempt. What these Black youth were less likely to happen is to have any known mental health problem or current disorder, depressed mood, suicidal thoughts and plans, or any past or current mental health treatment. And actually, this doesn't seem probably to make sense always when you try to put this together, because when you think about if the youth were highly likely to have a previous suicide attempt, but they were not in treatment, they had no known mental health problem. So where is this disconnect in which these Black youth are being missed and they're being at risk of suicide deaths? And what do we need to do to sort of help figure out what is happening and how we can build these safety nets for these youth? One of the other recent studies that came out, this was looking at school data across the United States. There's a survey called the Youth Risk Behavior Survey, in which many high schools complete across the country. And it has a range of types of risk behaviors, but they have items that focus on suicide. And one of the things that was noted is that they showed that over time, from 91 to 2017, Black youth had increased rates of suicide attempts, while other race and ethnicity rates declined. And they also had Black boys had increased rates of injury from these attempts. And that also Black girls were increasing their suicide attempts. And so this was another thing, that this is a risk factor that was unknown before. And someone recently extended this data to 2019, because the previous one stopped at 2017. And as you see, Black youth, they are the dotted line, and they are increasing over time. And it's even a further increase from 2017 to 2019. And so one of the things that this comes from a recent commentary that I want to bring up is suicidality in Black youth has been steadily increasing, yet there's limited evidence of why or even how to best intervene. And so this is the dilemma that I struggle with. Clinically, I talk about when I say is that we know the data is clearly showing us that Black youth are at increased risk for suicide attempts and suicide deaths, yet we don't have the data, and we have to treat youth in our practices without the evidence base that we need. And so this is the dilemma, and the goal is that the kids are still before us, even though as we wait for more research evidence at this point. So the next thing I want to talk about is screening. In the chat, I would like to know, there may be the screening question already put in there. So, okay. So whether people in your practice, okay, there we go. You can look at the screen and chat in the answer so I can just get an idea of whether we're screening.
So I think the question was, does your workplace utilize suicide screens currently? And it looks, Dr. Boyd, like we're getting quite a few that saying yes and using similar ones like the CS.
Yes, I do see that. Okay, that's great. So I'll go on. I just wanted to get a feel as we talk about these, and I'm not going in very specific detail about a lot of these, but currently where it stands about screening for suicide, the U.S. Preventive Services Task Force says there's not enough data to determine whether universal screening of suicide risk for adolescents is recommended. So it is not currently recommended. And part of the issue and how evidence needs to be decided is that we have to say that once you do universal screening, that it captures the people adequately and reliably, but also that it produces beneficial health outcomes. And that's what we do not know currently. And I am hoping that we will have that data soon because we recognize there's increased need. I wanted to go over a project that I did with some colleagues at University of Penn. We looked at a large sample, urban sample of youth and looked at their report of suicidal ideation as well as their parent report. And this sample had a large number of Black youth in it. What we found is that most parents were not aware that their child had thoughts of killing themselves or wishes of death. And so we can't rely on only asking parents. We do need to get this information from youth because parents may not be aware. And there was also a group of kids who denied it when their parents said yes. One of the things that we found when we looked at youth of racially diverse youth, they were more likely for their parents not to be aware, and they also were more likely to deny it when their parents endorsed it. And of the racially diverse youth, the majority of those were Black youth. And so there are things missing that we need to be able to gather this information from multiple sources. This is information from the Youth Suicide Risk Behavior Survey that I mentioned. Someone looked at the suicide items and said, how many kids omitted answering whether they had a suicide attempt? And the group that had more likely to not respond to that item were African-American Black youth. And they didn't differ from the American Indian or Native Hawaiian youth, but they differed. They were more likely to say no than the other racial and ethnic groups. And so there is some interpretation that this answer is being missed or skipped because the youth actually has a suicide risk. And that's something we don't know for sure. But Black youth may be underrepresented in these surveys, especially if they're missing the items. I saw someone did mention the suicide screening questions. This was a study recently done in emergency departments across the country. And they did two different types of screenings. They did a selective, only when youth came in and said there was a behavioral health issue, a suicide risk, did they screen them with the SQ. And then the other one, they did a universal screening and they compared the two. And what they found is actually with universal screening, that there was these kids that were picked up that were likely undetected because they were not coming in for that as their presenting problem. And so that was almost 58% of Black youth would likely be undetected if they were not given it in a universal way. So I'm glad to see that many of you had endorsed that you were doing universal screening in your clinics. I'm just presenting what we're doing at the Children's Hospital of Philadelphia. We have a suicide pathway. And so we do the Columbia at every initial evaluation and actually at every appointment, all treatment sessions. We have to at least do some brief Columbia. It doesn't have to be the full one since the last appointment. And as you all may know, as you probably have been switching over, that took a lot of practice, learning about it, putting it into your practice, but then it becomes kind of normal part of your practice and is a part of the electric health record, and it actually helps ease the flow of how you assess and actually how you follow up in documenting that in a way to make sure full risk assessment is done. So next, I'm going to move on to risk. And
Dr. Boyd, there is a question that came in the chat that I'm wondering about screening. And it said, can you speak more to why universal screening isn't recommended when the ASQ picked up so many youth who would otherwise have been missed?
Yes, so that study, it was done several years ago, and they looked at what was currently out. That recent ASQ study is more recent. And so what I'm imagining is that the US Preventative Task Force sort of makes these decisions based on the wealth of research data that's available. And so although this was actually noted, one of the things that they also have to show is that doing universal screening makes better health outcomes for youth. And so we need to push when people are doing research to say whether it actually improves kids' outcomes. And so that's the data that also is needed. And the person who developed the ASQ, I was on a call with her recently, and she said that probably be another search through the literature to kind of see whether there's more evidence base to move this forward for universal screening. Okay, so I'll go on. So next, I will be talking about risk and protective factors. So I'm gonna present this conceptual model that was recently published. So one of the things that have occurred is that many of the conceptual models that focus on suicide do not include youth of color. And so particularly someone, Opera and her colleagues developed this to talk about sort of what is happening for Black youth and the risk factors that we need to consider when putting it in full context. So they incorporated the individual character risk factors such as hopelessness and family support, but also some of the immediate environment, peer groups, exposure to discrimination and racism. Also these issues at the community level, whether there's violence in the community, poverty, and then also culturally, how is racism, sexual orientation, and how all these factors come into play and how we need to consider this and how we view the patients that are presenting with us and these youth risk. And so I am hoping that there will be some more models that will be coming. I know some people are working on this, but I do want to think about sort of understanding kids in their ecological framework and context in which they live. Some of the commonly reported risk factors are those typically associated with suicide risk that we know. And some of the ones that have been sort of some support for Black teenagers, it's been depression, externalizing behaviors, poor family support, substance abuse, and diagnosed mental health disorders. And so those things seem to be common among many youth. One of the things that we want to talk about with depression is that with depression, there's 9 symptoms of depression, and depression can look different in different youth and in individuals in general. One of the things is that we know that internalizing symptoms are more likely not to be diagnosed with Black youth, and sort of why does this happen? And there's something about when we're doing clinical assessments that is missed. And so I wanted to just kind of give an example. So the teen A has sort of what we would say the typical symptoms of depression. So someone come in with sadness, withdrawn, they're tired all the time, they're in bed sleeping, multiple naps, they feel horrible about themselves. I'm imagining that most people would say that's depression in a teen. That would be some that could be. I think sometimes it's complicated because that teenagers may present with depression differently. And particularly with Black youth, I think this particularly the symptom of irritability, which is a symptom of depression in youth. And so sometimes when Black youth are seen as irritable, they're seen as problematic, having an attitude, and is viewed as externalizing and not an internalizing problem. So you can imagine a teen, Black teen presenting being irritable, they have difficulty concentrating, they don't sleep much, they're waking up in the middle of the night, staying up all late, they're eating a lot and feeling guilty. That fits the symptoms of depression, but that could be diagnosed as another disorder. And so, and not an internalizing disorder. And so I think part of this is sort of how we interpret different symptoms and put them together and recognize what depression is for Black youth. I want to give example of some qualitative data that was given in Baltimore, and this is focusing on an urban Black adolescent and sort of their experiences. And it talks about, you know, depression, experiencing violent crimes in their neighborhood, losing neighborhood trust, this feeling of being disconnected to their environment, under stress with lack of resources, not being able to do enjoyable activities because of safety, and not having that protection, and how that kind of adds to this depression picture that they have. Also want to present that this also is a study from Baltimore in which they looked at specifically in middle schoolers, suicide, community violence exposure, and is linked to suicidal ideation later. And so among boys, they actually found that there was a direct link with both depression symptom and aggressive behavior, linking to suicidal ideation and attempts. But for Black girls, this went only through depression symptoms, not through aggressive behavior. And so it is important to actually look at sex differences also, that boys and girls may be presenting the symptomatology and the risk differently. And I do want to talk about racism and discrimination. Over the last year, there's been many, many discussions about this topic. And one of the things, a recent study came out in which they showed they follow Black youth and had them fill out data every day. And they found out that Black youth average 5 racial discrimination experiences per day. And this includes online discrimination, in person, witnessing, as well as directly to themselves. And when I saw this number, I actually was shocked that these Black adolescents was experiencing these many incidents of racism a day. And I think it's important to understand that and for us to ask about this and when we see you. One of the other studies that actually kind of affected my practice was that Tynes and colleagues actually looked at youth exposure to online traumatic videos. So they looked at both Black and Latinx adolescents and looked at the videos they watched and how did they feel. And they found that kids who were exposed to more traumatic videos had higher levels of depression symptoms and post-traumatic stress symptoms. And so when I saw this study and these findings, it had me change my practices in which when I see youth, when an incident happened, which there are many incidents that happen in which it's all over the media, it's all over social media, I directly ask them now, are they aware of the situation? Have they actually watched the video? And I check to see how many times they watched the video. So what I've been working with youth to do is to not continually watch the videos over and over again. And so sometimes it has to be getting off social media because of the images keep coming across. And so I do talk with them about, should you watch it at all? And I do understand that they may want to watch it based on their age. Since I work with teenagers, to watch the video once, but I really discourage them and I explain to them the negative impacts it will have on their mental health and what I'm concerned if they continue to watch the videos. And so over this last year, I've had many conversations with youth about sort of their feelings, their thoughts about sort of these videos, the police killings and things that have happened that dealt with racism. That is a lot more that has happened previously, But in a sense, I had to incorporate that into my clinical practice because youth have been affected. I've done it in the past, but it is even more so because these youth are being exposed to so much through social media, and we have to sort of include it because they are experiencing more depression, anxiety, fears, and they're struggling with how to handle all of that in their own identities. Also, youth are also, when we think about intersectionality, that youth who are LGBTQ youth are also experiencing discrimination based on their sexual and gender identity, as well as racism. And so they're doubly bombarded with the stress that they're encountering. And then I think as someone put ACEs earlier, I saw this is an ACEs report that came out in 2018. And these are the ACEs that are the highest for Black youth. So economic hardship, parental, divorce, and separation. And these two are for all youth across all race and ethnicities. But the other two, parental incarceration and family violence at home, are the top four that Black youth are dealing with. And so it's important for us to understand these impact of the patients that we see and whether that puts them at risk for suicide, because we do know ACEs have negative impacts for both mental health and physical health. And I also want to talk about maternal psychopathology and family history. So having, there was a study that looked at parents who had, mothers who had a suicide attempt. And what they found out, and these are with young kids between 5 and 9, parents who had a history of a suicide attempt, and half of the sample, the mothers were Black. The kids have higher negative life events. They also had higher negative affect. They tended to be less comfortable. They were more sad and less able to soothe themselves early on, before they may be exhibiting sort of psychopathology. And in a study that I did several years ago, in which I looked at Black mothers with depression and their children, and I found that actually almost a quarter or more than a quarter had recent suicidal ideation, and that was on a depression screening measure. And so this is saying there's a high risk knowing that there's a parental psychopathology present. This is a study that we recently did at the Children's Hospital of Philadelphia with people at Penn, and we looked at people with a family history of suicide attempts also. And we found, we matched them with people who did not have this family history. We found more psychopathology, more lifetime suicidal ideation, greater trauma exposure, more likely to have a lower economic status, and had executive functioning problems. And so these kids having that family history could not think through things as well, which puts them at risk for suicidal and making decisions and impulsivity later. So I want to go on to the protective factors because there are protective factors also. When we think about protective factors, there are things that have been noted across many studies. There's the strong family support. And I noticed that as that was a risk factor before. Also religious and spiritual engagement, community, social support, and then personal factors. You know, when people feel good about themselves, they have well-being, they perform well in school. And then financial factors, stable housing, income, and employment. And so if you notice, some of these themes come across the risk and the protective factors that seem to matter. This was a systematic review looking at risk, parenting, family factors among youth, Black youth, looking at specific outcomes of depression and anxiety. And so one of the things that they noticed that having positive parenting actually was associated with less depression and anxiety, and that seemed pretty consistent. Also with discipline, it actually having more harsh discipline increased depression and anxiety. Parental monitoring seemed to be a protective factor. However, the evidence was not as clear. Psychological and behavior control did not have an impact. And so I think one of the things that is important is about this is that in particular, that relationship with the parent, and parent is an important component. So many times, and particularly when you see adolescents, and I know that happens with me, that teenagers come from school, they come to my office, they catch public transportation when we were in the office, and come in for therapy, and then parents aren't as actively involved. And I think this is the part about the importance of including parents in treatment in different ways. Family treatment is not always warranted, but in a sense, that there's check-ins, helping to keep kids safe, having that positive parenting relationship, working on if there's a major problem, including parents. And particularly with Black youth, we know that this is a protective factor, and that we need to make sure that there is some parent involvement in the work that we do in treatment. Racial socialization is another topic that's come up that's really an important construct. So it's defined as really specific verbal and nonverbal messages that are transmitted to youth, sort of to help them develop the ideals, values, and beliefs that is important for their race, their interactions, and their group identity. And this has been seen as a protective factor, and this has come up a lot where you may have heard about the talk. Black parents are actually performing these messages, racially socializing their kids to deal with racial stressors, racial discrimination, and how to handle them. And so this has been seen as a protective factor in which Black youth actually have better self-esteem and better outcomes when they have positive racial socialization in their lives. One of the things that does come up, and I'm imagining, and I'm not sure if it comes up in some of the your practices that you see, is that, the kids are dealing with these issues, and how do me as a therapist help them with this, but I'm not the parent. And so how do we handle this? And oftentimes, and I'm not sure, I guess people can chat whether this comes up in their, this comes up in your practices? I guess a chat about sort of racial socialization and how parents.
Dr. Boyd, do you want to repeat that question?
I know, I'm sorry, I'll say it again. So I wondered, does it come up, this issue of racial socialization in the practice when you practice with teens, about how do you, does it come up as an issue about how they're socialized about racial issues and how to deal with racial discrimination? Yes, it seems like it comes up. Mm-hmm. And so, oops, sorry, I didn't mean to go that way. I'm reading the chat. Every time I read the chat, it seems like I speak. Okay. So it does come up for some people. So this does come up, and oftentimes I do try to check in with the parent to figure out what messages are they saying, because I don't think it's my place. I try to help kids sort of maneuver things, and that I know their family may be putting sort of their own values, and it's not my place to put my own values in it. So I try to have this conversation with you about what they're learning from their parents. What do the kids think are important, and how do they maneuver this, and maybe give them strategies or have these conversations with their parents, because I think it's important that they have these conversations with their parents about how to deal with these situations, or extended family members sometimes. I know I'm not missing. Okay, someone's talking about the racial matching issue. Sorry, I know I am gonna, okay. Great. And so also, which very related, is ethnic and racial identity. And so this is a construct, a belief in which youth develop their ethnic and racial group membership, and then the whole process about the beliefs and attitudes they develop. And this happens over time. And so sometimes youth may changed in how they view their racial and ethnic identity, how they construct it, particularly when you're working with teens. There's a process in which they're trying to figure all of this out, and it's normal. And it may vary. I recently met a new patient, and they told me they didn't know what their race was. And so I was kind of stumped, but I recognize that's where they are. And so I tried to have that conversation, but I was also able to talk with them about, how their identity placed within their school context. And they were also able to talk about those things. And then some people that we are, particularly I've noticed in our clinic, we've been having a lot more kids who are biracial or multiracial. And so that also comes up as an issue in sort of how do they identify, and if they are identifying with two races, what does that mean? And so I think this is important to have these discussions, to recognize that they change over time, and that in that process that it could be a protective factor for you. So this is an example, also Times and colleagues did, which I love her work, in which they looked at online discrimination. And they looked at whether you've had a low ethnic identity or a high ethnic identity. And if you see, when there was a high online racial discrimination happening, that youth that had a high ethnic identity, it was protective for them. They did not exhibit as much anxiety. And so it's like, when a stressor happens, do you have the personal resources to deal with it? When things are not stressful, youth may do okay, but we know they will encounter multiple stressors, and we want to build their protective factors, and so that they will be able to deal with the stresses that come up. Also want to talk about in that concept is the context of racial congruence. And so in your neighborhood is the extent to which an individual in your neighborhood is similar to other people, racially, ethnically. And then it has been some evidence, and this is not totally conclusive, but showing that racial congruence within a neighborhood may provide a protective effect. And also racial school congruence may provide a protective effect. And so this is something I think we need to understand more exactly what is happening. But one of the things that I do recommend is inquiring about the neighborhood racial ethnic composition of the youth and how they identify. So typically when I see my patients, I try to understand their neighborhood, try to figure out who are the kids who are in their neighborhood. But I also try to understand their school composition. How is it made up? What are they experiencing? Who are in their classes? Because sometimes, in particular schools, some schools could be more racially diverse for Black youth. And then for some of the Black youth who may be more high achieving in their classes, they may be in classes that they don't have as many Black youth, and how that may impact them. And so sort of understanding this, and also their peer group. So who they choose to hang out with may vary. And so they may all vary. When you think about a high school student, they could live in a neighborhood that's one racial ethnic composition. They can go to a high school that is a different racial ethnic composition, and their peer group could be even another one. And trying to put all those pieces together as they're figuring out their identity, and us understanding the context in which these youth live. And so knowing this information has been very helpful for me. I've identified subgroups of youth and sort of been able to help me kind of keep track. I have a group, kind of a subgroup of Black teenagers that I see that have their peer group are Asian youth, and they like K-pop and they like anime. And so as I identified that that is a group, it helped me to be able to, keep up with what's happening with K-pop, understand what anime was, and sort of to understand what does that context, when their peer group may be different than the neighborhood they go to, or what their family may not understand their peer group or their interests. And so those things are helpful in putting the whole context and where that may cause stressors at home and in their lives that may increase their suicide risk. And I also want to talk about higher income, because as I mentioned, economic stability is a protective factor, but is maybe not that simple. And so as Asari and colleagues actually looked at two large databases, and they looked at this issue for Black youth and income level. And they found different findings depending on the group. And I find these findings interesting and food for thought as we think about the context of the youth that we see. So they found in one study that higher income was protective factor for Caribbean Black youth, but that also higher income was associated with more depression for African American boys. And so there was a difference based on the ethnicity. And then in another study, they found that higher income was associated with greater depression for Black youth living in predominantly white neighborhoods, but that it was associated with less depression for Black youth living in areas with more Blacks. And so this is the understanding the context. So it's not just that income, sort of where you live, who you live, your experiences all come together to impact your risk for depression, which we know is a significant risk factor for suicide. So I want to end on thinking about the variability and the intersectionality among Black youth, because many times we talk about Black youth, we don't consider that they are not all alike, and that we need to take that into context. And so part of it is that, knowing the community that you are working in, the kids you see, that is important. Socioeconomic status, religion, the place, as we say, the neighborhood, ethnicity, the family immigration history. Did the family come from a Caribbean island? Did the family come from Africa? Did they come from the South to live in the North the generation before? Looking at gender, sexuality, and the school's environment, private, public, charter schools, what types of different schools they've been through, putting all that into context as we see you, and what does that mean for understanding their risk, and also how their presentation of mental health disorders may be. And we use any of these for protective factors. And if we have to make a safety plan or try to increase some protection in our treatments. And so these are issues that are important to assess. So one of the things we all know that when we have an assessment, it's too short of a time, we cannot gather all the information. And so what I think is important is that, in the therapeutic relationship over time, that we gather this information and understand it's not going to all be gathered in that first appointment that is short, and you're trying to make sure that the kid does not have a suicide risk, and understand the diagnosis that we have to give. So, but I do want to put that into context. And before I go on to just some general recommendations, I want to kind of give an example of sort of how all of this could play a part, a case presentation. So I want to present a 13-year-old middle school girl who presented for treatment for depression, for therapy. So this was actually after being psychiatrically hospitalized for a suicide plan and threat. And so it came out of the blue. The patient had never had any mental health diagnosis previously, never had any treatment, but in the middle of a normal morning getting ready for school, and the mother saying, "Get ready for school," said, "I want to kill myself." And so that led to a hospitalization and into mental health treatment. And so the patient presented normal depression, typical depression that you see, sad, withdrawn, slept a lot. And so started treatment on medication and treatment. So that's what we'll typically recommend for recommended treatment. So lived with both parents, had 2 siblings, lived in a low socioeconomic neighborhood that had a lot of violence, went to a local middle school that was predominantly Black, high achieving student on honor roll, participated in the sport and in treatment. So those are some of the risk factors or the presentation. So what over the course of treatment and in high school, over a course of several years, several things come out. And this is one of the things that we may not know everything initially when we present. So some of the stressors over the course that the depression worsened, it got better, but worsened, especially during high school, which we know is a great risk factor for, when depression may get worse or even exhibit itself for youth. Particularly chronic depression, a lot of hopelessness, wanting to die, 2 serious suicide attempts during high school that led to medical hospitalization as well as psychiatric hospitalization, several different intensive care, frequent cutting. One of the things that happened also that increased risk, there was a sexual assault during high school, which then revealed that there was a previous incident of sexual abuse at a younger age, which was never revealed in many of the contexts before, but came out late. And so also was revealed that there was, father had substance abuse issues. And there was a lot of strain in the marriage because of that, as well as conflict. Also, later on, almost near adulthood, it was found out that the patient was gay. And so all of those things occurred over the course of 5 years. And so one of the things that when we think about what are the risk factors? So the risk factors was there was a depression, there was initial history of suicide plans. There was also issues that had to come with that. There was family stressors. There was a violent neighborhood and there was a history of abuse, but protective factors, the youth was high achieving. The school was very supportive. I had frequent contact with the school counselor, and also that the parents were supportive, as well as that they were supportive when she came out in her sexuality. The sports was actually a supportive factor that helped too. Family owned their own home, they went on vacation, so there was economic stability. So one of the things is these risk and protective factors occur in one person. They aren't like a one-to-one match. We have to put it all together. But eventually the patient did get better, their depression got better, their suicidality decreased. But it was a long course. And this is probably typical type of patient that I see, and that many times is a course of sort of treating both psychopathology as well as the suicide risk. So I know we're running late on time, so I just want to, I guess, just want to talk about sort of make sure we gather this information to incorporate, and that is important for us to identify this as an important priority in our practice. So I'm ending here so we can take questions. So.
Sure. Thank you so much, Dr. Boyd. It sounds like a lot of what we're talking about here is really sort of taking the time to understand the context in which the individual you're working with is functioning in, and all those various sort of recommendations you have, and that it can't necessarily always be a one size fits all, that it may be more of an individualized conversation around trying to understand all these various risk and protective factors. In the example that you gave, do you have any recommendations? Because those were sort of things that came out across a number of years. Are there any recommendations for trying to tap into some of those risk and protective factors sooner or earlier? ideally to prevent any future attempts. Do you have any thoughts there?
No, I think that's a good question. I think I brought up that because sometimes, in particular, kids don't tell us things that we know. And that's why, and this does come up as an issue, whether this is more likely in Black youth, that there's things that are not told until this relationship or things happen. And so I think it's important for us to ask these questions, sometimes to ask them again at later points as the trust is built, because sometimes in that first meeting, I know all the information I get is not true. Particularly, they many times lie about substance use and sex is always some of the things they usually lie about. If there's some family secrets, things they think may put them at risk, they may not tell you at some point, or they may not be ready. So I think it is important for us to try to get that information, but think we need to maybe try again to get this information at a later date. And especially particularly when treatment is not working well. We know something else is going on. And we have to sometimes figure that out.
Great, thank you, Dr. Boyd. And I do want to point out, we do have some questions to answer, so we'll be able to get to a few of those in these last few minutes. I do want to point out that Dr. Boyd is coming back on July 14th for another second part to this presentation, where she'll go deeper into interventions and additional recommendations. So one question that came in, which I think is important to talk about, is the current sort of pandemic context. So is there any, have you seen differences, or are there additional concerns related to suicide among Black youth during this current context?
I was going to talk about that in the second one. Can we hold it off, or you want me to start? Because I do have some, I was going to have that be one of the topics for the second part.
Yeah, I think that's probably fine. So just ask
Okay.
you to kind of join back. That's not a problem. Yes, they said not a problem.
Okay, thank you. So
do you have recommendations for talking to parents when you see some potential risk factors around suicide?
yes, I mean, part of it is that we actually should definitely have the conversation with parents, and it can go multiple ways. Sometimes parents are open, sometimes they have a hard time hearing it or sort of understanding why their kid needs, or they think is a phase that they will go through. So I try to keep it simple and let them know sort of what we know in a simple way. If the kid is exhibiting depression, one thing I do think is important for them not to minimize when you say they want to die. I think that's the part you hear where they didn't mean it, they didn't say that. Like, we take that very seriously, and that there's a reason we take that seriously, because we don't know, will they act upon it at some point. And so trying to explain that to parents, that that's important, and also explaining what to do, because I think many times they may not know what to do. And so we talk about, if we, the more serious end, if they think their child may harm themselves, where the crisis center at, where the emergency room, and what's need to do. But in some sense, can they sort of help their child de-escalate their emotions or talk it out? And what could be some sources for parents sort of to help in that conversation? I do tell parents to check in with their kids, particularly when kids at risk, and sort of how to do that. And many times I have to get that from the kid, because sometimes the kids, like, if they don't stop asking me, how you doing, and looking at me like, they get upset. So we try to figure out what is the best phrase word or that they can say. So we want to make sure that parents and kids are on the same playing field, and they understand what should happen and how to have these conversations and communicate.
And you may get this more in part two as well, but I think there was some mention around sort of youth not being open to talking. And I think it was also in your example that the reticence in sort of sharing and opening up. I'm also thinking that related to a separate question earlier around sort of racial match or cultural match between the youth and the provider, where that also could play a role in not being as willing, as open to sort of it not being as open, because maybe you feel that they may not understand where you're coming from, or it may not feel safe yet to kind of share. So Any thoughts or recommendations that you can provide around how to have some of these conversations, how to even explore sort of, those risk and protective factors while encouraging them to really open up? How do you create that safe space?
I mean, I think that's important. I mean, I think racial matching does matter in building initial therapeutic rapport. It may not always be necessary, and there's not enough providers for it to always be the case. Sometimes that does not matter for you. Part of it is building that connection. I try to ask things pretty direct. I think sometimes when providers may ask questions where the kids may not feel that they want to hear the answer to, I put the suicide questions kind of in the top half of the evaluation typically. Once, I see people more regularly, they know this is what I ask you all the time. And so this is a regular question. But I try to build that rapport in that first appointment, a little more understanding their family, find out about their friends, their symptoms. And then I bring in the suicide so they get an idea to talk about it initially. But I do know someone may not. I mean, typically they're coming in for mental health. Some of the times where not everyone may be in environments where, like if you were in the emergency room and they were coming for something else, asking a question about mental health may be seen more often. I also think some of the issue that does happen is that kids may think there are negative outcomes when they say, I'm going to kill myself. And so parents or families may think that the child could be taken from them. I mean, so I think there's still some miseducation. Things will sometimes happen that are not unpleasant when they got to go to emergency rooms and hospitals. They're not pleasant situations many times. Going into a psychiatric hospital is not particularly pleasant. So that is the piece of trying to work through those kind of things. And that's maybe sometimes why people are afraid and may not tell, because they don't know what will happen.
Thank you, Dr. Boyd. We actually have a few questions and I'm wondering, maybe we hold for the next one because they're more specific around sort of how you have that conversation if there is concern of suicide risk. There's also some questions around types of recommendations, treatment recommendations, and the like. And I think we're going to get into that in part 2. So I think what we'll do is we'll take all those questions and feedback and make sure we respond to those in part 2, either through the presentation or through any of the Q&A as well. So because we're at time now, so don't want to hold people up any longer. Thank you so much, Dr. Boyd, for a wonderful presentation, very enlightening presentation. Thank you to our audience for being so interactive and responsive. And I strongly encourage you to please come back. I believe everybody who's already registered for part 1 is already registered for part 2. So just check your emails for the link to access it on July 14th. If you have any questions or concerns, email us at ctac.info@nyu.edu. We also shared with you a feedback survey in the chat. If you can click on that and respond and let us know what feedback you have about this presentation or any recommendations for future presentations, that would be much appreciated. We do read all of feedback on a regular basis. And I just wanted to remind everybody that this is being recorded, and the recording and the slides will be posted on the ctacny.org website within about a day or 2. So thank you again, Dr. Boyd, for spending the morning with us and talking with us about this very important conversation. We're looking forward to seeing you again next week.
Thank you for inviting me. I look forward to part 2, so please come back.
Great. Thank you so much, everybody. Have a great rest of the day.